Hello, this is Dr. Michael Conte, and today we will be talking about the osteopathic approach to the cardiovascular patient. Our objectives for today's presentation are to review pertinent cardiovascular and neurologic system anatomy, to identify viscerosomatic reflexes common in this type of patient, and to use that information to enhance differential diagnosis and treatment, to discuss the role of OMT in these patients, describe Chapman's reflexes, and create an appropriate approach to OMT dosage in patients with cardiovascular considerations, as well as discuss research in this area. To start with some of the anatomy, from a developmental standpoint, the heart forms in response to a growing central nervous system in order to pump nutrient-rich fluid more efficiently and effectively to the CNS and later to other structures of the body. From a skeletal perspective, the heart is protected by the rib cage, sternum, and thoracic spine. Myofascially, the myocardium is housed in a pericardium, which is adherent to the diaphragmatic fascia and anchored to the great vessels. From a neurologic perspective, the autonomics, the SA node, AV node, and the intrinsic rhythmicity of cardiac myocytes all play a factor. Vascular, you have your sympathetic innervations and intrinsic endothelial function. And in regards to lymphatics, channels within the heart muscle drain lymph, and congestion can quickly become severe when it occurs. In the neurologic model, there's the sympathetic nervous system and the parasympathetic nervous system. On the sympathetic side, you have T1 through 6, and right-sided fibers from these regions pass to the right deep cardiac plexus and go to the right heart to the SA node, and irritation or activation of these fibers can cause supraventricular tachycardia. The left-sided fibers pass to the left deep cardiac plexus on the left side of the heart and innervate the AV node, and excitation of this area can cause ventricular fibrillation. Increased sympathetic tone in the body can cause increased force of heartbeat, shortened systole, increase in ventricular output and contraction rate, blood pressure increases, mortality and morbidity jumps after acute myocardial infarction, inhibition of collateral circulation, and increase in coronary vasospasm and vasoconstriction of the blood vessels. On the parasympathetic side, the vagus runs the show. The right vagus innervates the SA node, and hyperactivity can cause sinus bradycardia. The left vagus innervates the AV node, and hyperactivity in this region can cause or contribute to AV nodal blocks. All structures within the heart have lymphatic channels and drain lymph through the heart, from the endocardium to the myocardium, epicardium, even the valves and the conduction system, and they all drain into one main lymph channel on the posterior side of the heart, which then drains into the right lymphatic duct. Congestion of the cardiac tissues may result in arrhythmias, like 6 sinus syndrome, and peripheral congestion has been implicated as causative factors in atherosclerosis and hypertension. And it's most easy to see the effect of lymphatic congestion in the peripheral and pulmonary edema, ascites, and hepatomegaly seen in congestive heart failure. Myofascial tension in the transition areas of the spine can also potentially restrict fluid movement as the venous and lymphatic return is under low pressure. The areas to look for in particular are at the occipitolateral junction, around the jugular foramen, cervicothoracic junction, around the superior thoracic aperture, thoracolumbar junction, around the diaphragm, the lumbosacral junction, and the pelvic diaphragm. And looking at more of a biomechanical model, we can see dysfunction here have an impact as well on cardiac function, specifically in cases, for example, scoliosis, where greater than a 75-degree curvature has shown to be seriously compromising of cardiac function. Also, flattened thoracic kyphoses have been associated with tachyarrhythmias. In addition, poor posture, causing Travell trigger points, which we'll talk about in a moment, can also cause or even sustain tachyarrhythmias. Compensatory musculoskeletal problems may also negatively affect cardiac function. Relay gait should be analyzed and treated in patients with compromised functional activity from diminished cardiac output, as an abnormal gait may increase cardiac work by up to 300%, which may surpass the patient's energy reserves and lead into some of the diseases we'll talk about shortly. In addition, somatic factors may play a role in cardiac concerns in that these may mimic chest pain or anterior chest wall syndrome, which may mimic cardiac pathology, but actually be caused more by things like somatic dysfunction of the cervicals, thoracics, and ribs, costochondritis, also called Tietze syndrome, intercostal neuritis, and also myofascial trigger points, and even rib fractures, especially after open heart surgery, all can cause anterior chest wall pain, which may mimic cardiac pain. In regards to the Travell trigger points, There's a so-called cardiac arrhythmia trigger point located below the lower border of the fifth rib between the nipple and lateral sternum, which can be associated with supraventricular tachycardias and actually can be resolved with treatment of this point. In addition, going back to musculoskeletal complaints, pectoralis major and latissimus dorsi trigger points can also cause chest wall pain, which may mimic cardiac pain, and which should also be tested for in patients to be able to differentiate between those two causes. As far as referred pain, viscerosomatic pain from cardiac disease, as you can see in the previous slide, the trigger points are very similar to the referred pain patterns, classically from cardiac viscerosensory reflexes. And again, from the coronary arteries, or your classic angina, you see upper left chest pain, which radiates down the inner left arm to the hand and the end of the fourth or fifth digits. It may also refer up the neck into the jaw. Classic pain distribution into the dermatomes of C8 through T3 signify more a ventricular involvement, while lower chest wall pain into dermatomes T4 through 6 is more an atrial involvement in regards to referred pain. Moving from the anatomy to more of the function of the heart, normal function includes the heart pumping continuously from the beginning to the end of life, also responding to the activities of daily living, sleep, sudden strenuous exertion, physical activity, which regulates, increases, and decreases rate and force of contraction. Also, heart muscle cells, again, have intrinsic rhythmic activity, in addition to the nervous system, sympathetic and parasympathetic innervations. Another consideration as well are emotional effects, such as anger and stress, and the effect that they have when you mix in the hypothalamic pituitary adrenal axis, and their byproducts, such as norepinephrine, epinephrine, and cortisol, and their effects on heart rate and contractility. In addition, vascular endothelium and smooth muscle also responds to inflammation and cholesterol and oxidative stress by laying down atherosclerotic plaques, which leads us to the disease or dysfunction of these major cardiovascular diseases, which include the list here, and by all means not a complete list. And treatment really is using evidence-based guidelines for cardiovascular disease. A lot of it does involve lifestyle modification for prevention of primary and secondary cardiovascular disease. But we're really thinking about the musculoskeletal system in that as many as even 25% of patients with heart failure have functional limitations really caused by that system and not by just the diminished cardiac output. So really OMT is used to decrease the allostatic load and really work on optimizing homeostatic reserve and mechanisms so as to decrease morbidity and mortality. So for a patient with acute coronary syndrome, what is our osteopathic approach? Well, in regards to OMT, really that is not your immediate concern, as the structural or functional issue is represented by the intra-arterial thrombus rather than the somatic dysfunction, and the homeostasis is really represented by increased cardiac output. So at this time, OMT really needs to be put on the back burner, and that'll be more important in the recovery phase. And again, it's very important that the osteopathic approach to acute coronary syndrome is not necessarily immediate osteopathic manipulative treatment. Really, the urgent issue is the thrombus, not the somatic dysfunction. So you may want to make sure you use the old adage, see the forest for the trees. You don't want to be so focused on finding somatic dysfunction and structural concerns that you miss the overall condition and don't treat the disease process. So what do we do for acute treatment of ACS? Remember your MONA, M-O-N-A, morphine, oxygen nitrates, and aspirin. Also concerning thrombolytics and revascularization as necessary. You really want to restore oxygen delivery to the cardiac muscle so you don't lose that muscle through ischemia. And then also after that, after the acute treatments, then you want to start thinking about these lifestyle modifications, including stress management, exercise, smoking cessation, dietary changes, and also medications, including statins, beta blockers, and antiplatelets. And then OMT, in this case, whether it's post-operatively or whether there was an operative intervention or not, especially in a post-op patient, you have additional somatic dysfunction because of the operative stress on the body. You really want to increase the musculoskeletal efficiency. Again, remember the abnormal gait and normal gait mechanics may increase the cardiac work by up to 300%. And in a patient who's already had some ischemic cardiac disease who has to come back from or has to heal from this insult to the system, those additional metabolic demands on the body not only impede healing but may precipitate a secondary event. So goals of treatment with OMT overall, really want to balance the autonomic tone. Again, we talked a lot about the nervous system and its and the effects of disease on the system. So really you want to relax arterial tone, improve venous and lymphatic drainage, get your cardiac contractility and heart rate back to normal to decrease that metabolic demand on the heart, and also get their kidneys perfusing and balance your fluid levels. Really, again, decreasing the impact of somatovisceral reflexes, and supporting homeostasis and optimizing the patient's function, and all that improves the healing process. Again, acutely, your approach really, when you get to OMT, very easy, and you really want to work with the patient here, especially in a post-operative setting. You don't want to put them through, let's say, an HVLA of the thoracic spine, even if you find a dysfunction there, as they've just had their sternum cracked open, and it's going to be quite painful. So really, indirect or gentle direct techniques are the most appropriate to use in this scenario, and treat your facilitated segments first, your really aggravated areas. But make sure, again, you listen to the patient, and if it's too painful for them, or if there's something that they can't handle, or if they're overworked, back off a little. For more of a chronic condition, kind of start the same way, but you may be able to use more active techniques, a little more patient involvement. Again, that might require more metabolic demands on the body, since they will have a little more reserve, will be a little more through the healing process, and it won't cause more strain on the cardiac system. Especially want to pay attention to the lymphatics, as again, you want to make sure you have proper drainage, such as the case of CHF, where you have a lot of fluid buildup, and also to improve blood flow and make sure you're getting oxygenated blood to the body tissues that they need. So specific regions to look at include the thoracic inlet. Remember that right lymphatic duct, which drains a lot of the cardiac lymphatics. Rib motion, such as rib raising techniques. Redoming of the abdominal diaphragm. Looking at the cervical spine, C3 to 5 for phrenic nerve, to also make sure the diaphragm is working properly. And also lymphatic pumps to move that fluid, including pedal pump, abdominal, and thoracic. And then there are Chapman's reflexes, anterior and posteriorly. What are Chapman's reflexes? Well, they're hypercongestion from hypersympathetic tone to deep intercostal fascia, and they result in lymphatic edema and myofascial thickening, which is reflected under your fingers as this painful nodule. It's really described as small, smooth, firm, and discreetly palpable, approximately 2 to 3 millimeters in diameter. And we utilize this in OMT not only as a diagnostic modality, but to treat. And actually, studies have shown that manipulative treatment of Chapman's reflexes by applying a rotatory pressure at the posterior points for the adrenal glands in the intertransverse spaces of T11 through 12 have shown a 15 millimeter of mercury drop in systolic blood pressure and an 8 millimeter of mercury drop in diastolic blood pressure, and also a reduction in serum aldosterone levels that persisted for 36 hours. So by finding these points and applying this rotatory force, we can impact the tissues and the viscera below. Now specifically in this case for the myocardium, the anterior Chapman's reflex is located between the second and third intercostal space, adjacent to the lateral edge of the sternum, as you can see by the arrow here. The anterior Chapman's reflex for the adrenals, that can also help one find or detect stress in the cardiovascular system, is about 2 inches above and 1 inch lateral to the umbilicus on each side, as you can see here. Also, the kidneys are about 1 centimeter superior and 1 centimeter lateral. So if you find the kidneys, go up 1 centimeter and then you hit the adrenals. And with the posterior Chapman's reflexes, you also have a myocardial Chapman's point, and that's superior and lateral to the third thoracic spine. Again, looking at the adrenals, that is farther down the spine and located lateral to the spinous process of T11. And again, the kidneys are just below that. Again, to treat with Chapman's reflexes, you want to use firm pressure on the finger pad in small circular patterns in order to mobilize localized fluid accumulation. And the small circular motion should be applied for 10 to 30 seconds or until this mass disappears. Now, research into the efficacy of Chapman's reflexes has been limited, but Menino D.O. studied hypertensive patients and reported in the Journal of the American Osteopathic Association in December of 1979 that a 15 millimeter of mercury decrease in systolic blood pressure, an 8 millimeter mercury decrease in diastolic blood pressure, as well as a decrease in serum aldosterone levels for 36 hours following Chapman reflex treatment was reported. And this just shows that by treating these Chapman's reflex points or addressing these points, you can have effect on the rest of the body as well. Here's just a sample treatment of what one might use as far as OMT in the acute myocardial infarction patient. Now again, this is after you've already done your acute medical interventions, and this is more of the post-acute stage where you've already gone into your secondary prevention, your risk prevention strategies, and are working with OMT as far as helping to optimize that homeostasis and function. So in this case, you could address the sympathetic innervation, again, T1 through 6 of the heart, T10 to 11 through the adrenals. You want to avoid excessive sympathetic stimulation, as that will cause a increased metabolic demand on the heart and can lead to further problems, more ischemia, etc. You can use empiric techniques such as paraspinal muscle inhibition or rib raising to treat these areas. In addition, looking at the parasympathetic innervation, more at the OA and the AA, you can treat specific somatic dysfunctions there first, or if you don't find a particular segmental dysfunction, you can use empiric techniques such as suboccipital inhibition or release. To address the lymphatics and vascular drainage, you want to look at the thoracic inlet and abdominal diaphragm, where you can do thoracic inlet release, and again, rib raising if you haven't already. And then address the Chapman's reflexes, the bilateral second interspace for the myocardium, and again, the adrenals are superior and lateral to the umbilicus. And again, in these patients, use caution with OMT, as their autonomic system is quite sensitive, and any undue force through that can aggravate or can increase metabolic demands through the heart, can exacerbate their symptoms, and cause a lot more damage. So again, the real goal of treatment is to reduce the musculoskeletal burden as well as some of the viscerosomatic and somatovisceral reflexes to try to find that optimized homeostasis in the patient. And again, here as it mentions below, acute heart failure patients, you may not want to use this technique. If they're stable, you may be able to, but uncompensated acute heart failure, you really want to go with your primary medical treatments first, and then wait till their body's a little more stable, and then you can add OMT as an adjunct. Now, as far as research in the osteopathic field in relation to cardiovascular concerns, the research has shown that diagnosis of somatic dysfunction in the areas known to be impaired due to facilitation from diseased myocardium and hypertension is predictable in location and enjoys about a 29% correlation with invasive procedures in the diagnosis of coronary artery disease. It also demonstrates differences in palpable findings according to the location of a myocardial infarction. What the osteopathic literature severely lacks are well-controlled studies addressing the use of osteopathic manipulation on the standard treatment outcomes of cardiovascular disease intervention, of decreased symptoms and hospital stays, and decreased morbidity and mortality. In this study, Beal and colleagues examined 99 patients one day prior to angiography for evidence of somatic dysfunction. The physicians performing the musculoskeletal exam and those performing the angiogram were blinded. There was a 79% correlative predictability for palpable signs of coronary artery disease as compared to angiography. In Fitzgerald and Stiles, they found that OMT significantly lowered the incidence of arrhythmias, shock, and mortality in post-myocardial infarction patients. As Dr. Stiles writes, by removing dysfunction, DOs can affect the diseased tissue by improving the blood and venous and lymphatic circulation, neurological flow of impulses, and oxygenation. Dr. Cox and colleagues studied 260 patients undergoing cardiac catheterization, 163 excluded for valvular disease, musculoskeletal disorders or deformities. 97 underwent musculoskeletal exam between 0 and 7 days post-catheterization. The musculoskeletal exam included range of motion, tenderness, and pain, tissue texture abnormality, and positive cutaneous red reflex. The results of this study showed that catheterization revealed 71% of patients with greater than 50% stenosis in at least one major coronary vessel, and 29% without evidence of coronary artery disease. Musculoskeletal exam revealed 2 of the 4 parameters, range of motion and tissue texture changes, were significant predictors of coronary stenosis at the left T4. In Beal and colleagues, they examined 99 patients one day prior to angiography for evidence of somatic dysfunction. Physicians performing the musculoskeletal exam and those performing the angiograms were blinded. There was a 79% correlative predictability for palpable signs of coronary artery disease as compared to angiography. In the Nicholas study, they looked at patients post-myocardial infarction and those who ruled out for myocardial infarction but had coronary artery disease, and found that the MI patients had tissue texture changes in a more precise location in T1 through 5 than the non-myocardial infarction patients. In Rosero, they studied patients post-MI, comparing the terminology used to describe somatic dysfunction, and found that patients with anterior wall MI were more often described as having, quote, resistant, tense, firm, quote, or temperature warm, end quote, tissue texture changes, while those following inferior infarction were more difficult to categorize. In Johnson, They published long and short-term studies of hypertensive adults, 4 through 8 months and 3 through 10 years of hypertension, and found in both cases a persistent pattern of somatic dysfunction at the levels of C6, T2, and T6. Forbert, looking at musculoskeletal pathology in patients with angina and normal coronary angiograms, found increased radiographic findings at the levels of C4 through 7 and T1 through 6. And with Yervati in 2005, the study was looking to determine the effects of OMT on cardiac hemodynamics post-CABG surgery. They measured the thoracic impedance, mixed venous oxygen saturation, and cardiac index. And OMT was performed within 2 hours while the patient was intubated, sedated, and paralyzed, and performed directly to the T-spine, ribs, sternum, diaphragm, upper cervical region, and Simpson's fascia. The results of the study showed increased thoracic impedance, mixed venous oxygen saturation increased, and an improvement in the cardiac index. So they conclude that there's a possible reduction in length of stay, postoperative complications, edema, and arrhythmia associated with these changes. These are the references I used in preparing this presentation, and thank you again for watching. We'll see you in the lab.